right, good morning, everyone. Talk about some imposter syndrome here. This is awesome. I feel very honored to be on this panel, and I'm here to talk with you about my research on affirmative mental health care for sexual and gender minority youth. So I'm a clinical psychologist by training, which means that I'm really interested in thinking about these mental health disparities on the individual level. So what can we do to change an individual's experience with these mental health disparities? So to give you a brief overview of what I'm hoping to accomplish in 10 minutes, or probably less, for questions, first I want to tell you what I mean by affirmative mental health care, and specifically why I think it's really important to take a developmental approach to this when we're talking about care with youth. Second, I'm going to talk about why I think this is really important, particularly within our current sociocultural environment here in the South. And then finally, with the last few minutes I have remaining, I'll talk about what I think this looks like and some future directions for my research in this area on evidence-based interventions with sexual and gender minority youth. So when I talk about affirmative mental health care, that's a fancy word for saying I'm going to validate a youth's identity when they come to my office. Who they say they are is important and real and true, and that deserves to be validated. Taking a developmental approach to this, though, we also recognize that identities are evolving and fluid, particularly in adolescence. And so it's important to continue affirming those identities, even in a context where they might be changing. So my colleagues and I were interested in this question of how do things change over time, because in fact we do know that sexuality in particular is quite fluid over lifespan. So we assessed a broad group of adolescents in North Carolina and followed them for 3 years and asked them to tell us about their sexual orientation identity label, their sexual romantic attractions, as well as their sexual behaviors. And what we found was that particularly for girls, these things were incredibly fluid over time. So 26% of girls reported one or more changes in their sexual orientation identity label over the course of those 3 years, compared to 11% of boys. And 31% of girls reported one or more changes in their romantic or sexual attractions over that period, relative to 10% of boys. So what this really underscores for me is that affirmation is important, and affirmation in the context of change is also important, because we know that change is common. This brings me to my next point, which is that affirmative care is important to take within the developmental context of youth. Adolescents are not simply little adults. We can't pull down models from adulthood and apply them to adolescence. They do need to be taken within the context of developmental changes that are typical for all adolescents. So to provide kind of the best care for individuals, we need to take into context their own developmental level, their peer and family influences, and a variety of other developmental factors that are going on for that particular youth. So I want to tell you just briefly about one of the studies that I did with my colleagues at UNC and Wake Forest. I was interested in thinking about what is the developmental context for sexual minority youth in particular, and particularly thinking about their social context. We know that the transition to adolescence is characterized by a number of shifts, namely increased focus on peer relationships rather than relationships with parents or family. We also know that at this transition period, youth become increasingly sensitive to social feedback from their peers. So what we did is we went into a school district in North Carolina and we assessed all the teens in a couple grades. And we asked them to tell us who their friends were. And by doing this, we have this really cool ability to then map out their in real life social networks, which I just think is so cool. So each of these dots represents an individual teen. The lines between them represent their nominations of who their friends are. Those blue dots represent sexual minority students based on their own self-report, and then the red are sexual majority students. So in mapping this out, we could look at some really interesting trends. So sexual minority youth were statistically less likely to be nominated by other peers as their friend. They also nominated fewer friends themselves. Though importantly, their friendships were more likely to be reciprocated. So I say, you're my friend, and you also say that I'm your friend. The other interesting things that came out were that these sexual minority youth were located in less central or less prominent locations within their social networks. So they're more on the outskirts. Their social networks were also less cohesive or less dense. What's really interesting, though, with the study is that we then looked at alcohol use. We saw that across teens who had friends who reported drinking alcohol were more likely to drink alcohol themselves. However, that relationship was actually less strong for sexual minority youth. They appear to be less susceptible to peer influence around alcohol use, which was an unexpected but also really encouraging finding. So why ask these questions now? Why am I concerned about affirmative mental health care for youth at this point? Well, we know that the prevalence of LGBT identities is rising, particularly among the youngest generation right now. So we're seeing more youth than ever identifying as sexual and gender minorities, and we need interventions that work to meet their unique mental health needs. And the reality is that we have very little evidence about what works to help support these youth. These questions are also really critical in our context here in the South. It's quite reasonable to expect that there's a variety of aspects of the culture here that might contribute to higher frequencies of minority stress experiences. For example, we know that we live in a region of the country where conversion therapy is not banned, despite the fact that this is a practice that is known to be ineffective and actually quite harmful for youth. So when I think about youth coming into my office with this context, that's really powerful, right? To hear that might be an experience that they could have when they're seeking out mental health care. And then finally, we've been talking a lot about these mental health disparities broadly in this population, but we know that these mental health disparities start emerging early. So as early as childhood and adolescence, we're seeing differences in sexual and gender minority individuals. In some of my research, for example, I looked at data from the CDC's WIRE-BS data. We found that gender nonconforming adolescents were at higher risk for suicidal thoughts and behaviors, even after accounting for their higher risk for depression symptoms, which was really powerful. This brings me to where my research and my clinical interests really lie, which is what does affirmative mental health care look like for this population? Again, we have very little data on what works, what are our evidence-based interventions to support the mental health needs of this population. And so this is my goal, is to think about what does this look like? How can we show that this is actually effective in meeting these unique needs? From my perspective, mental health care would involve 3 primary domains for this population. It would involve identity-related support, addressing interpersonal functioning, and then treating co-occurring psychopathology. Clearly, we know that all 3 of these domains are really interrelated. Some work I've done with the Gender Care Clinic here at Duke actually has shown that for youth who reach our clinic later in adolescence, they show higher rates of depression, higher rates of anxiety, higher body dissatisfaction. So that interplay between some developmental factors around coming out or having support from parents to bring them in really is related to their mental health functioning when they're actually presenting for treatment. So what remains to be seen with this model is where can we use existing evidence-based interventions to treat these health disparities versus where do we need to develop some novel interventions? So for example, can we simply use cognitive behavioral therapy to treat higher rates of depression? That would be an established evidence-based intervention. Whereas where might be some new interventions we might need to address. So for example, how do we intervene to change parenting behaviors that communicate rejection towards sexual and gender minority youth? Or are there ways to use psychological interventions to reduce the severity of gender dysphoria in adolescents to kind of augment treatment that they might receive through a multidisciplinary care clinic like the one we have here at Duke? So this is my passion, and my goal for my career would be to move in a direction where we could develop some kind of adaptive interventions that can meet the variety of needs in this population. Because what's really clear is that sexual and gender minority youth are not a population that's defined by shared psychopathology, right? They're defined by a shared identity that then is associated with these higher mental health disparities because of minority stress experiences that they have throughout development. So.